Hey everyone, it's Kate again. I'm just going to fly through a quick presentation on medication administration. I know that medication administration is something that you studied in EMT class, so we'll try not to beat a dead horse. And the bulk of the learning will likely occur during lab if you have not had exposure to this topic. So these are the routes of administration that we need to demonstrate proficiency in before the end of the course. Inhalation is a piece of cake. Oral, don't know that we even need to touch on that. Same with sublingual. Subcutaneous, I'm going to show it to you in this presentation, but currently there aren't any drugs in the advanced EMT scope that are required to be given in the subcutaneous route. So we'll just talk about how you do it and then we'll move on. Intramuscular, you do that with epi, but we'll just make sure everybody's good with drawing up drugs for intramuscular injections. IV, woohoo. Intranasal, you already know how to do that. If you have any questions, let me know. And then intraosseous, we separate out intraosseous into its own module towards the end, and then add the math and put it all together for the pediatric population at the end of the course. A nebulizer is a way of delivering a medication via the inhalation route that takes a liquid and turns it into a very fine mist for inhalation. We talk about administering beta-2 agonists, sympathomimetics, bronchodilators via the nebulizer route. And you can see if you break down that word, sympathomimetic, it mimics the sympathetic nervous system. It mimics the effects of a dominant sympathetic nervous system. The two drugs that you'll be giving are albuterol and ipratropium. When they're put together, they're called duoneb. You can give them separately. And basically you're going to fill the reservoir, set the flow meter to 6 liters per minute, not too fast, not too slow, so that you achieve a nice fine mist. And also know that you can load multiple doses into the nebulizer. Most of us are using figure A here, the simple face mask that has the nebulizer reservoir towards the bottom there, right above the O2 tubing. And what it does is it allows the patient to have hands-free medication administration. So the mask is attached to their face with an elastic cord, just like an O2 mask, and they don't have to do anything. They just sit there and take some nice easy breaths. Figure B and C show you how you can use a nebulizer and have it connected via a T-piece if you were bagging someone or using CPAP. This version of a nebulizer is called a T-tube, but it requires that someone be holding it up. It also requires that the patient form a seal around the mouthpiece to take breaths in to get the medication in, so it's not always ideal. So this is an example of a subcutaneous injection. The main thing to notice is the angle of the needle relative to the surface of the skin. So by by inserting the needle at a 45-degree angle relative to the surface of the skin, the needle is entering into the subcutaneous tissue, or that adipose tissue, which is primarily comprised of fat, so that the medication is being delivered outside of the muscle. And this should be good if you wanted the medication to absorb more slowly and you wanted to ensure that the medication didn't get into that highly vascularized muscle. But we don't have any medications currently that we are required to give in this way, so I'm just showing it to you so you know how that works. These are the common sites for subcutaneous injections. I'm supposed to give injections into people's bellies, and it literally makes me nauseous every time I do it. I can't do it. Here's the same format picture, but for intramuscular, and you can see that the angle of the needle is different. It's more straight on, 90 degrees relative to the surface of the skin, going as far in as you can to get to muscle. It may be deep depending on the amount of subcutaneous tissue that your patient has. It may be relatively shallow if your patient is older, or thinner, malnourished, has less subcutaneous tissue. But you can see that the goal is to get that needle down into the muscle. So these are the preferred intramuscular injection sites. Certainly, I think the deltoid is the most commonly utilized injection site for epinephrine and glucagon intramuscular, and you would not be incorrect to give those drugs in that location. If you read our protocols, the rectus femoris is mentioned as the preferred site for epinephrine injection intramuscular, and I believe the vastus lateralis is also mentioned. But it's not easy to get to people's legs unless they're wearing shorts or a dress. So if it requires that you have to pull their pants down, you got to consider whether or not that's what you really want to be doing. You would not be incorrect in giving an intramuscular injection in a deltoid. This is a visual representing an intravenous push. You'll note that the syringe is connected to a needleless connector, the blue piece right there, so there's no needle involved, and they would have wiped that clean with an alcohol prep pad prior to connecting the syringe. And you'll also notice that the operator is crimping the tubing above the injection site to make sure that the medication that they're delivering is going down into the patient. That is a pretty flimsily secured IV if you ask me. But what is nice is if you look at that green 18 gauge catheter, you can clearly see where that catheter enters into the patient and travels up the course of that vein. So as the operator is giving this intravenous push, that person is feeling for resistance, and they're also keeping their eye on the IV site to look for signs of swelling or assess the patient for increased pain. I think we're working on like 18 years of intranasal administration. If anybody has any questions, let me know. And this slide is there because I'm like 15 inside. The intraosseous route is a wonderful addition to the scope of practice for the advanced EMT, and I'm really happy that Vermont decided to expand the scope to the adult population. And so I think you'll find that it's pretty reliable. It's pretty easy to insert, and with proper technique, it has about a 98% success rate as opposed to IVs, which are about a 75%. For IO, we'll be using the tibia for pediatric and adult patients, and the humeral head will only be used for the adults, no children. So one of the things that I think is really, really, really important is that you are very clear on what your service has for packaging of medication, whether your service is using epinephrine in the form of an auto-injector like an EpiPen, or are they using a multi-dose vial that you draw up each individual dose, or are they using an ampule that will require multiple steps for you to draw that medication up safely. Whatever the case it is, we'll try to give you exposure to expired medications so that you can play with them and look at them and read the packaging, because it's super duper duper important that you are able to read the packaging and pick up the key bits of information about what's contained in how the medication is supplied. So the medication for inhalation via the nebulized route, those come in little plastic bullets. There's unit dose syringes that are sometimes referred to as an amp, and you'll see that there's a glass or a plastic amp of medication with a separate syringe that you flip off the tops and screw together. It's kind of exciting. There's multi-dose vials with self-sealing tops that are in the next slide. Unit dose vials where there's only one dose contained within a vial. That's a safety feature. And then glass ampules that take a little bit of practice but are pretty cheap. When you're administering a medication via the injection route, it's important to understand that there's different sizes of syringes and there's different gauges and lengths of a needle. And so it's important that you're selecting a syringe volume that's appropriate to the dose and a needle gauge and length that's appropriate to the type of administration. So if you were going to do a subcutaneous injection, a short little skinny needle would be fine because you're just trying to get into a superficial part of the tissue. But if you want to do an IM injection of glucagon or epinephrine 1 to 1,000, you might want a needle that's a little bit longer, like an inch or an inch and a half. The volume of the syringe must match the volume of the medication that you're going to give. So if the dose of epinephrine 1 to 1,000 is 0.3 milligrams and it's the concentration is 1 milligram and 1 milliliter, then that means that you're going to draw up 0.3 milliliters, and that's less than a milliliter. So it becomes very important that the syringe that you're using is less than a milliliter and it's marked off in tenths of a milliliter so that you can draw up to the 1, 2, 3 and make sure that you're getting 0.3 milliliters. And just a note, if you look down here in the lower right of this slide, you can see that you should always use a leading zero when you're trying to write something that's less than 1. So 0.3 draws attention to the decimal that you're using less than 1. And you should never use a trailing zero. So when I say right down here in a 5 milliliter syringe, I would never write 5.0 because that could easily be mistaken for 50. So leading zeros are always a good idea. Trailing zeros are never a good idea. One of the things that you'll notice as you start playing around with medication administration and IV therapy and intraosseous is that there are some things that have safety engineering built into the product, and then some things that you can still purchase that have no safety engineering. So if you look at the box of needles there, 25 gauge, 5/8 inch single needles, the packaging down there, those little blister packs, those are just straight needles, right? So once you are finished using them, they got to go straight in the sharps container. Conversely, the picture of the needle on the right, that has a self-capping mechanism that prevents needle stick injuries. Unit dose syringes are convenient because they contain 1 dose of the medication in the packaging. So it's a way of limiting the potential for overdoses. I just want to point out here that on this container of 50% dextrose, the standard really is to give the patient 10% dextrose through an IV. And we'll show you how to do that. But if you do give dextrose 50%, the goal is to start with a half of a syringe. So 25 grams is in an entire syringe. 12.5 grams would be half of the syringe, or 25 milliliters, and see how the patient does versus just jamming the whole syringe in. Although it is kind of fun to watch them wake up. These are some examples of multi-dose vials with the self-sealing rubber top. So there'll be a little plastic cap on there that you pop off. You wipe off the top with an alcohol prep pad. Enter the vial with a needle, draw up your medication, and then figure out how to either recap the needle, which is not a good idea, or dump that draw up needle and put on a fresh one to administer the medication. We do have a bunch of expired medications that South Burlington Fire was kind enough to share with us this weekend so that you can get some practice reading the different vials. If you look at this epinephrine vial here in the middle, that's pretty legible. So you can see it says epinephrine. The concentration is 1 to 1,000. All right, so it's 1 part epinephrine to 1,000 parts inert ingredients, and this particular concentration is 1 milligram per milliliter. So if you drew up 1 milliliter of this drug, you'd have 1 full milligram of epinephrine 1 to 1,000. When you're drawing up from a vial, they are vacuum pressure sucker saver sealed somehow. So the picture on the left is the operator pulling up a volume of air that matches the volume of liquid drug that they intend to pull out, and that just makes it easier to pull the drug out instead of trying to literally suck it out of a vacuum sucker saver sealed vial. The glass ampules are another way that drugs are packaged. They're very inexpensive. They've been around for a long time. They do require some practice to snap off the top and then attach a filter straw to draw the medication into a syringe without drawing up little baby micro shards of glass. And then you do have to discard the glass ampule as you would a sharps. I actually had a mentor at work who dropped a glass ampule of fentanyl and then stepped on it wearing Crocs, and it went into her foot. We'll practice with the glass ampules in lab if we can get some. The medication sometimes gets stuck in the top of that ampule, and so you have to flick it or swing it around to use centrifugal force to get the medication out of the top. When you break open an ampule, you have to protect yourself by using a 2x2 or an alcohol prep pad, and you basically snap it at the neck away from you. This is called a filter straw, and that's an example of drawing out of the hugest ampule I've ever seen. You attach this filter straw to the syringe that you're trying to get the medication into and draw it up using that. And then you just twist off the filter straw, discard it, and attach the administration needle. So just another push for confirming the 5 rights before you ever approach a patient with a medication. We actually have had advanced EMTs here in the district that were working with either students in programs or people who had graduated from programs that were handed the wrong drug by another person and assumed that the other person had checked it. So if you're the operator administering the drug, the onus is on you to confirm the 5 rights before administering it. I think it's important to recall that there's services out there that have both paramedic and advanced EMT. Hopefully everything's kept separate in like a medic bag or an advanced EMT run kit, but sometimes there's just one med kit, and there's a lot of drugs that look alike, sound alike, maybe have similar packaging, and for sure the writing is very small. So just make sure that you are verifying the 5 rights before administration and then documenting the 6th one. When I was learning to give medications as an EMTI student in 1990, one of the things that I was taught was to read a medication label out loud 3 times before I opened it and started to unpackage it. And I have since learned that that isn't actually a rule. It was just something that St. Michael's Rescue did. So I would pull out the box of D50 and I would say, this is dextrose 50%, 25 grams and 50 milliliters. This is dextrose 50%, 25 grams and 50 milliliters. And by doing that, I was verifying for myself the medication that I had, but I was also communicating with the crew around me. And recall that when we were talking about how we're all going to get good at doing our skills, verbalizing what you're doing is an important part of communicating with a crew so that everybody is on the same page. Another step for success that I just want to emphasize is that make sure that you're practicing how to draw up a medication and then administer a medication so that you are clear on the equipment that you require. I can't think of a more frustrating thing than to be sitting there ready to do something and realize, oh, I don't have an alcohol prep pad, or oop, I don't have a Band-Aid, and now my patient is bleeding after giving them an intramuscular injection. When this happens, you run the risk of a needle stick injury or making another mistake because you're now fumbling for equipment or supplies that you need. So be real careful there. When it comes to drawing up medications, it's critically important that you understand every single bit of information that's on the label, the volume that you're drawing up, the milligram or the dose of the medication, and keep in mind that those two things are different, right? So it may be that you're drawing up 12.5 grams of dextrose 50%, but the volume that you're going to push is actually 25 milliliters. So that's where understanding the concentration becomes critically important for you. Make sure you prepare your patient, but if it's an intramuscular injection and you think they're going to be afraid of needles or maybe an IV, it's probably better to start collecting your stuff and then get consent and then do it. So the longer that they have to think about it, they might become a little bit more anxious. When you administer a medication, try to note the time so that you can sort of set a clock in your head for the pharmacokinetics. When can you expect an onset of therapeutic effects? And then more importantly, what's the duration of those therapeutic effects, and will you need to redose? You should be making sure that you are reassessing and reassessing and reassessing for those therapeutic effects, but don't forget about the side effects or a reaction that would be unanticipated but you may need to deal with. So that's it for medication and I'm not re-recording this. Too bad. Okay, so here's our plan for proficiency. We will practice IVs every lab until everybody is signed off. We're going to do a route of administration every Thursday until we've covered all of the advanced EMT routes of administration, with the exception of intraosseous, and again, we put that more towards the end of the course. We'll have some skill sheets for you this Thursday. I'll have a little portfolio for everybody, but just to be clear, you have to get signed off in class before you can practice any skill on a real human, whether that's a friend, a foe, or a patient. And it's become clear to the team AEMT that if you're not practicing skills outside of class, you will not be ready for the exam. So if you have any questions about this, let me know and we can catch up on Thursday.